to mute.
Now not. Okay, good morning, everyone. Now, as Dr. Neha said, we are going to talk about the cognitive behavior therapy in general, how the cognitive behavior therapy would be helpful for diabetic patients. And because I'm seeing a lot of the participants today are not only on the diabetic field, keep in mind that the most of the information you will get from today, it's applicable to all the type of patient. So it's the aim today is to give you a little bit of information of my job, what I'm doing exactly with my job, and how understand if someone of your patient would benefit from session for me, how to identify them, and which are the codes that we need in order to make a proper referral, especially with TICA patient, because I know that the majority of us has TICA patient. So I will give you all the information. Let me open my slides. I try to do it as easier as I can. And the presentation is divided in two parts. Is divided in two parts, and in between the first part and the second part, I will ask any of you if there is any clarification needs or if you have a question. So the first part, it will be cognitive behavior therapy. So exactly what I am doing, what is my job is. And the second part is how to refer the patient and how to assess the symptomatology that is specialized for the diabetes patient, but it's valid for the majority of the patient we can see in our clinic. So let's start with the first part, as I said, was what CBT is, how CBT works, and in which area we can use the CBT as a good intervention. CBT is the acronym for Cognitive Behavior Therapy. So it's a therapy that has an action on the cognition, the way we think, and the behavior, the way we act. The second part, it will be how identify the symptomatology. So how we can understand if someone needs the CBT, what we explained on the first part, and how we can make a clean and efficient referral to the mental health department. So let's start with the first part, what CBT is. The cognitive behavior therapy is the therapy that aims to change the way we think and as consequence, the way we behave. So the main part of a goal therapy for a psychologist is to change the pattern behavior, to change the coping strategy of a patient whenever the coping strategy and the way they are acting daily, on a daily basis, it's creating impairment, it's creating symptoms, and is not functional anymore. So we start normally during the therapy, we start with the assessment of a patient. So the patient comes to us for the first time, and we need to assess which type of patient he is. So the most important information we need to have this assessment done in the proper way is to know that we are based on the personality trait. So the personality trait is what we build from 0 to 18 years of life. The reason is that in this period of life, our brain finished the development. So let's keep in mind that everything that is coming from the cognition and the behavior, it's coming from the prefrontal cortex. The prefrontal cortex is a part of the brain, and it's a part of the brain that change the structure, and as soon as developed in a different way, with all the experience that we have during the development period. So we can say that every experience from 0 to 18 years, negative, positive, small, traumatic, everything make our prefrontal cortex the way it is and make our personality trait the way we function normally. So we can consider the prefrontal cortex a sort of software that analyze the outcome from outside, from the ambient, analyze the information and make an output, which is what we think and what we do. So the personality trait is like a fingerprint, because if it's true that the development is changed by the experience and each of us has a different experience, each of us has a different trait of personality. In our field, we normally divide the personality traits in 16 clusters. So it's true that we are all different, but it's true that we are all can be labeled in a certain category. And each of the category has a similarity characteristic. I will give you an example because it's easy for me to explain it. My personality trait, it's an obsessive personality trait because I was raised in a certain way with a severe family and no mistake. So my structure is this type of structure. This is not necessarily something positive or negative. It's just the way we function, the way our software, our prefrontal cortex analyze and process the information that we get from outside. So let's say, let's keep using my example. Let's say that I have an obsessive personality trait. So when I am not in stress, when I am perfectly functioned, let's say, I don't have symptoms. When I'm overstressed or when the personality structure is damaged, let's say we will see later, we have a completely dysfunctional way. So the average of the human being are on 5. So we all are in balance between our personality traits and our way to function. So from 0, which is perfectly functioned, which doesn't exist. So there is no one that perfectly functions. To 10, let's say it's O.J. Simpson. We are all in between this scale. So we are all around 5. So what happens when we are under stress? When we are under stress, our personality traits start to process the information in the wrong way. So instead of creating a normal cognition procedure, we tend to create cognitive distortion. So thoughts that are not realistic, not completely realistic, they are not functional, or they are not appropriate for the context we are acting with. So keep please this scale 0 to 10, and 0 does not exist, and 10 is like the most bad serial killer you can imagine. We are all on 5. So what we need to do to understand which is the problem of the patient? First of all, we need to understand which is the personality trait. It's my patient an obsessive like me. It's my patient an avoidant personality. It's my patient a narcissistic personality. So which is the type of personality they have, and which give me the information of how he does work, how it does function in a normal daily basis. Then we need to assess which is the current situation and the stress factor. Normally, when a patient comes to us, they are not perfectly well. If they are coming to a doctor, any type of doctor, there is a problem. Any type of problem, which can be, for example, medical, or discovering a diagnosis of diabetes, or knowing that I'm diabetic, but I cannot manage my diabetes in the proper way, is a stress factor. So considering the type of personality and considering the current situation, what the patient is experiencing in this moment, we need to ask to ourselves, where is the patient in our scale from 0 to 10? So we will find people that is absolutely under stress and dysfunctional. We will give them 7, 8. There are people that are slightly under stress, but still impairing their life, still not functioning. So they will have a 5, 6, 7. And another information that is important to know about the personality trait is that we divide the diagnosis in mental health in 2 big groups. One is the axis 2. The axis 2 is when the personality trait structure is problematic. So when the personality structure is not working on a daily basis. This is what happened with traumatic childhood, abusive family. There are several things, but we call a personality disorder when the personality structure never goes beyond 7, and it keeps going always above 7, 8, 9 in our scale. So it's all the people that was affected by something in the first 18 years during the brain development. That's why the software has a bug. The software is not working properly. And then we have the second big group, the AX1, when the personality structure is stable. So the software works more or less. There are no many symptoms. There are not a big history of symptomatology in the history of the patient, but they are, for example, in a stressful period or in a high level of stress. So this is creating a poor or wrong coping strategies, creating an unfunctional way to analyze the information from outside. So the software is still an healthy software, but it's struggling to process the information from outside. So these are the intervention areas. So these are the type of patient you would encounter. So we have the obsessive compulsive disorder. It's all the people that you can spot them washing their hands very often, sterilizing everything they are touching, checking before have a seat in a chair if there is something in the chair. This is the cleaning type. Then we have the checking type, which are the people that will check often if they close the car, if they close the stove, if they close the door in the proper way, if the plugs of the electricity are completely dry. And you can recognize them because the pattern of the behavior is repetitive. Then we have phobias, which is an irrational fear of something. We have thousands of types of phobia, starting from the most common one, which are spider, snake, to very, very, very picky things, which is difficult to spot unless you are not in a setting as a psychotherapy. Then we have the post-traumatic stress disorder, which is what we have after a major traumatic stress. I will try to explain you a little bit more because this is something you can encounter more often in patients. So our brain has, let's say, two boxes to stock the information in our memory. One is the short-term memory, one is the long-term memory. So whatever happens to us today, it's stuck in the short-term memory. Whatever is in the long-term memory is what the brain decides to keep for good. How the prefrontal cortex make this decision? So which is the criteria that the prefrontal cortex use. It's the emotional activation. So again, let's use the scale 0 out of 10. If I'm drinking a glass of water today, my emotional activation will be 0. So the brain will put this memory on the bin. But if I have a car accident, for example, the emotional activation out of 10 will be 8 or 9. So my brain for sure will put this memory on the long-term memory. What happened when the traumatic episode we are experiencing out of 10 has an emotional activation that is 13, 14, 15? So the software, which is just a machine, doesn't know what to do because it's out of my criteria. So the memory got stuck in between the two boxes. So it's like a memory, but constantly active. So that's why this patient, they have flashback, they have like very, very weird reaction to triggers that for us are silly triggers. We will go back there too later. Then we have the schizophrenia. For this issue, I will refer you to Dr. Arash and Dr. Mufid because it's a psychotic disorder that needs to be treated with medication. Then we have the sexual disorder. The sexual disorder are all the type of disorder that impair the sexuality of a human being, and it comes from the psychosexual development, which is again from 0 to 18. So everything happened positive or negative in this stage from the sexual point disorder can create a sexual disorder. Then we can have the sleep disorders. It's normally on the axis 1 because we don't sleep when we are worried for something. We don't sleep when we are very tired. We don't sleep when we are stressed. So it's on axis 1. And then we have, of course, the diabetes, because imagine how a diabetes patient takes the diagnosis. Like the most common distortion are, I'm damaged, I have a problem, I have something that cannot be fixed, I'm different than other. So those are the most common cognition when we have a patient with the diabetes. Then we have all the addiction. The addiction, keep in mind, it's not only drug. An addiction is everything we cannot avoid to do. This is the reason why the addiction and the OCD, the obsessive compulsive disorder, are under the same level, which is the impulse, we call it impulse discontrol. So every time we have an impulse that we cannot control. So it's about drugs, it's about alcohol, it's about smoking, it's about gambling, it's about washing your hands in case you have an OCD disorder. They are all coming from the same cluster. The symptomatology is different, the treatment is different, but the roots from the personality structure is the same. Then we have the most common one you will encounter on your daily basis, which is the anxiety and the depression. Then we have a bipolar disorder. This is again a psychiatric disorder that needs the intervention of a psychiatrist with the pharmacological evaluation. Then we have the chronic pain, which is one of the most impairing problems we encounter during the therapy with a client. And then we have the eating disorder, when what is affected is our pattern of eating. We have a colleague, Dr. Virginie, that has a master in eating disorder. She is very skilled in this type of patient, and you know how often in a diabetes patient the pattern of how we eat is important in a way or in another. Because, for example, I had patients that since they discovered they have diabetes, they stop to eat completely because they link the food with something dangerous, with something poisoning. And on the other side, we have Patient that got stressed because of that, and they start to overeat, like the famous emotional eating. So even in each category, we can have different behavioral pattern. Now, this was the first part. There is any of you that have a question about it?
The chat box.
Chat box.
If anybody has a question till now, you can even unmute yourself and ask Dr. Claudia.
Yes.
I don't think there has been any question in the chat box also, and maybe nothing yet from the participants.
Nothing that is not perfectly clear?
I think it's been quite clear. Thank you.
Huh?
I think it's been quite clear. You've
Okay.
been given very good examples, so we can continue.
Okay, so now the second part is how can we identify this symptomatology and how to do a proper referral, and which type of codes use, especially for TICA patients. Why? Okay, so the first thing we need to say, it's something that we didn't mention yet, which are the emotions. So we talked about before prefrontal cortex, so the way we think and the way we behave. There are the emotion in between this chain. Now I'm going to explain you more in detail. So in each situation we think something, what we think create an emotion, and the emotion help us to decide what to do. So how to do an emotional assessment? What we need to understand is which is the emotion that our patient is experiencing and is empowering. So the main group of the emotion we have is sadness, happiness, anger, anxiety, frustration, shame, guilt, and disgust. So what we need to do during the emotional assessment, we need to ask our patient how many emotions you know, and ask them to list it and see what they are missing, what they are not missing. It's also these things, it's also helpful to have a common language with your patient, because maybe we are talking about sadness, but we use different words, especially here in this country where each of us come from a different culture with a different language, and we are sharing a language that mainly is not us. We need to be sure that we are talking about the same concept with the same word. So you should verbalize. Do you feel sadness? Do you feel happiness? What sadness means for you? Or for example, what do you think is the difference between anger and frustration? Because for the majority of the people, it seems like almost the same. So when we are clear with our patient that they know what we are talking about and they know what an emotion is, then we can ask them, how often do you have this emotion and how deep is this emotion? So going back to before, if a patient will tell me that his main emotion is disgust, okay, and it's often out of 180, and when it comes out of 100, it's 100, it's very deep, then we can imagine that we have an OCD on the bottom line. On another example, if someone highlights, I feel always sad, and then how often, how deep, and the number is high, then we can imagine that there is a depressive mood on the bottom line. So the emotional assessment for someone that is not a psychologist can be easily done with a scale, impairment scale, that is out of 100. So each emotion, how often do you have this emotion? How deep is this emotion when it comes? So the way we assess the emotion it's important, because the emotion comes from the cognition. So if I have, for example, fear 100 for a snake, for example, which is obviously a phobia, we can imagine that the thought that is creating this emotion is all the snakes are dangerous. All the snakes are poisoning. If I encounter a snake, I'm gonna die, which are all, I would not say not realistic, but exaggerated. So we call it, sorry?
Sorry, Dr. Claudia, you can continue. That was by mistake, I think.
So you can identify that they are not realistic, and this is what we call cognitive distortion. So it's a thought, a distorted thought that gives a high negative emotion, which has as a result a symptom, a behavior that is symptomatic. So this step in between, this emotion, is how we interpret the situation and how we react before the behavior. So in each situation, as we say, we have a thought. So a core belief on an interpretation of the reality. Then we have the emotion, okay? The emotion, we already assess the intensity and the frequency, and because all of this chain, we will have a behavior that is resulted. Keep in mind that because each of us has a personality trait different, in the same situation, each of us will elaborate the information in a different way because of our personality trait, okay? So the results, even if the situation is exactly the same, the results can be different for each person. This is the reason why the patient with the diabetes diagnosis have different reaction starting from the same situation. So we can say that what we think affects what we feel and the way we act. We can say that what we do affects what we think and what we feel. And we can say that what we feel affects the way we do, we act. It's all correlated. Let's do an example. Imagine a doctor during a normal setting consultation, let's say with a diabetic patient, but as I mentioned at the beginning, this can be used for the majority of your patient, even if they are not diabetic. So a doctor is recommending a diabetic patient, to change his lifestyle. You need to exercise more, you need to eat regularly, you need to eat less, you need to eat more, you need to take your insulin on the right spot. So with this situation, the thoughts could be, I will never be able to do it, it's very difficult, this is the cognitive distortion. Then the emotion will be denial, fear, frustration, anger. Then of course the behavior related would be, I will not follow the instruction, not because I think they are wrong, but because my software is not processing the information in the correct way and give me at the end of the chain a symptom, which is the not adherence. On the other side, if we want to imagine someone with the same situation, but using the prefrontal cortex and the personality trait in a functional way, they might think, oh, finally, I know what was wrong with me. I'm excited to try a new solution. I want to see how I can improve, how I can be better. So the emotion related would be, I'm motivated, I'm happy, I'm finally, someone is giving me a solution, so this makes me happy. And the result will be a completely different behavior. So we will have someone that is absolutely adherent to his to the recommendation, someone that will never miss the glucophage, someone that will never miss the insulin, someone that will never exceed in carbohydrate if the diabetic education told them exactly which is the amount of carbo they need to intake daily. So as you can see, when we have someone that is showing, let's go back here, a thought that is not coherent with the reality, an emotion that is high in our impairment scale, so how often, how deep, and whenever we see someone with a behavior that doesn't look functional, then is the case to refer. So we can say, like as a resume of everything, that we can refer a patient to the mental health department every time the frequency and the intensity of a negative emotion is impairing his patient life. Okay, or every time the adherence of the treatment is not followed, every time we spot something that is it doesn't look like healthy. And we are going back to the OCD, someone that is washing his hands very often, someone that has an eating disorder, it's overeating or not eating, someone that is often sad. Those are all the situations in which you can refer to the mental health department. Keep in mind that our mental health department has a team, has the psychiatric department and the psychologist department. So the the people that has to be referred with TICA to a psychologist must be Dr. Arasha or Dr. Mufid, because TICA will cover only if the referral comes from a psychiatrist. So the referral from your side has to go mandatory to Dr. Arasha, then Dr. Arasha or Dr. Mufid will refer to us. If they are cash paying or any other insurance, they can be referred directly to the psychologist. Unless you spot delusion, hallucination, you understand that the patient is not adherent with the reality. So in that case, the refer has to go straight to Dr. Arasha or Dr. Mufid for a psychiatric evaluation and for a pharmacological evaluation. We have some tools that we can use to make easier our assessment. We have the impairment scale, which is what I explained to you, 0 to 10. How do you feel 0 to 10? You are good, 0, or you are very bad, 10. We can use the same scale for the emotional assessment, which emotion, how deep and how often. And then we have to scale the PHQ and the GAD-7. The PHQ, it's a scale that assess the depression and give us a number, give us a cutoff. So below or beyond, it's depressed or not. And GAD-7 for the anxiety. Works in the same way. It will give us, it will give you a number that will help you to understand if we are on an anxiety disorder or in a depressive disorder. When they are not in these two main categories, but you still have an impairment scale that is above 6, 7, even in that case, you can refer to the mental health department. Another information from last year, the PHQ and the GAD, it's mandatory from the DOH to all family doctors. So all family doctor has to assess anxiety and depression from the first place of the visit. So this this is a practice that should be more common because it's a very easy tool. It's 5 minutes to be done, and it gives us really a lot of information. Something I want to highlight that it's very important, in the PHQ, there is a question about the suicidal thoughts. Like very often, especially if we are not in a psychotherapy setting, a patient would not declare verbally, I have suicidal thoughts, but it will spoon the line of the question, so we can smell that there is something on that side without put them in the uncomfortable situation of verbalizing it. Now, the most important thing for today, because this is what the main problem we encounter every day. So we need to follow the DSM-5 version revised to code the disorders. Of course, none of you that is not a psychologist or a psychiatrist is deep inside the mental health code. So a good advice for you whenever you refer, it's use the F43.23, which is adjustment disorder with mixed anxiety and depression, which is, let's say, omnicomprehensive, then can be changed by Dr. Arasha after, or from Dr. Mufid after a specialistic assessment. But in any case, it's a code that is always a valid code for the mental health department. And it's a code that is recognized by TICA, so it will go through with not so many problems. And with this, it's everything.
Very comprehensive, and you've covered some very practical tips about what codes to put and how to refer, and also the red flags where we need to refer urgently or they need to see a psychiatrist urgently.
Exactly. This is the most important things. Like in terms of insurance, they need to pass by Dr. Arasha or Dr. Mufid in any case. But if you spot delusion, hallucination, or anything that is bizarre, then they have to be referred straightforward to the psychiatrics with urgency.
Have any possibility of emergency care in psychiatry right now?
Sorry, can you repeat? I was flashing my nose.
I'm saying, do we have here any like urgent care or emergency care for psychiatric problems? Like
The
if
only
they go
one,
to the emergency.
The only one in Abu Dhabi is Sheikh Khalifa Hospital. So another important thing, we treat in our clinic as outpatient, not critical care patient. So whenever we have a suicidal intention or a suicidal thoughts, what we need to do is send them straight forward to the Sheikh Khalifa Hospital. We cannot manage with this type of patient because it's dangerous legally for us and for them. And they can be referred to emergency room of the Sheikh Khalifa Hospital, which is the governative one, and it's the only one with the psychiatric department that can evaluate the severe critical emergency case.
They are comprehensive, to the point, and easy to understand. Sends his blessings as well.
Thank you.
I am still waiting for people to ask any questions they may have. I'm sure all of you have a lot of questions related to patients. It may not be related to diabetes, but you can still ask Dr. Claudia, and she'll be happy to help you resolve that. I have one question, which is something I face practically with my patients. Many a time we have pregnant patients with mental health issues. They are going through postpartum blues, postpartum depression. There are, I see a lot of perimenopausal and menopausal women with a lot of anxiety and mixed symptoms. They could be hormonal, they could be, underlying other disorders. But whenever I try to bring up psychotherapy or a psychiatric consultation, there's a bit of resistance or a bit of, what do you suggest? What is the best approach to, bring people, make it more acceptable? Or is it the way we say it? Is it something
There are few tips. It's very common, especially in this culture, but even in Europe, I would say that it's still a taboo. So what the people think automatically is psychologist, psychiatric. I'm cuckoo. I'm crazy. So automatically they feel judged. That's why you perceive this reaction. What we can explain them is that going to a psychologist is not necessarily having a problem and then fixing the problem. It's also try to talk about ourselves and learn more about ourselves. A metaphor that I always use that works is, for example, your body. If you want your body to work better, you will go to the gym. There is a trainer. The trainer will tell you which type of exercise doing to improve this or that. On the same way, you have a brain. Your brain perfectly works. There is no gap. But maybe there is someone that can give you a tips to function better, to be more functional. So we also have to put the accent of improving a skill you already have more than fix a problem that I spotted.
That's a very, very good tip, because yeah, changing the perspective on that might make it more acceptable for them.
No, not always works.
Yes, but
can I add something to this, Neha? Hi, everybody.
Hi, yes.
My boss.
I think it's important sometimes, Neha, when you present the need for seeing a counselor or a psychologist or a therapist, to present them as part of your team. So rather than saying, I'm sending you somewhere else, you say part of our team is that sometimes we require psychological assessment or support and of course, ideally, I think if you are able to train part of the OBG obstetric team, maybe a skilled nurse or any kind of person who has interest in counseling, just to train them in kind of the basic level of counseling. Once you start that dialogue with women, I think they are more likely to accept referral to more specialized or senior psychologists if there is a need. Because the majority of issues like baby blues, for example, you mentioned, it doesn't necessarily require a clinical psychologist. Somebody with basic counseling skill can provide the needed psychoeducation and guidance.
I really like that idea of presenting us as a team and saying that, this is somebody I constantly work with, as if, I need your help to manage her and not that she needs your help.
Yes, exactly. And if it's presented as part of the usual process, sometimes just like you may have to see a dietitian as well because there's some dietary problems, or, if somebody with diabetes, they may have to see the podiatrist. If it's presented in the same way that psychological help is really part of the overall care for diabetic patients or obstetric patients and so on, they're more likely to, because you then normalize it. It's not like, oh, I think there is something wrong and we need someone to see it. It's like, okay, this is part of a comprehensive assessment that we are offering.
Good idea. And I think on that point, we are working on trying to have a CBT workshop in the beginning of next year. So that would help a lot of primary care physicians, OB-GYNs, pediatricians.
Yes,
to maybe.
Yes, absolutely. Very good idea. Thank you, Neha.
If anyone else has any other questions or concerns, you can see the whole team is here, and we are very good opportunity to ask your questions that ever you face with a patient or a situation.
Yes, I have a question. Can you hear me?
Yes, and please give us your name also.
My name is Mir Ibrahim. I'm a physiotherapist, sport therapist. Sometimes we face patients or athletes with acute injuries, like, for example, tearing of ACL, and they go through a lot of emotional aspects of this injury. How you can initially deal with this type of injuries to just calm them down?
So the first thing you need to identify which is the main emotion, because not all the time is immediately fear. Like lots of the people with chronic pain, for example, has anger main than anything else. So the important part is to identify which is the emotion. And then the most important thing is to validate the emotion. What means? It means that if someone is declaring that I'm very upset for this injury because there is no way I can go through it, we can just say, yes, I understand how you do feel. You have the right to feel in this way. We need to validate the emotion. We cannot, we normally automatically try to minimize. We normally say, don't worry, it's going to be fine. Don't worry, it's going to be better. The message they will perceive on the baseline is not taking me seriously. So he's not understand which is the level of pain I have. So the first thing is validating the emotion. Then once they feel validated, you can start to say, look, we have solutions. Let's talk about the solution. Let's decide together what to do and involve them in the process so they will not feel like left on a side. The other thing that is important about the validation, it's something that needs to be used with any type of patient, because most of the time the complaint I receive when I'm seeing a patient for the first time that is referred from outside is that doctor doesn't understand what I said, that doctor say that is not so severe. So what we, especially in my job, what we need to do is treat the emotion, not the reason why they have this emotion. So if someone is coming to me with a severe depression and in the impairment scale, the sadness is 100, and the reason is I broke one of my finger, we still need to consider the results in terms of emotion, not the reason why they are there. So it's important for them to do not feel judged, to do not feel we are minimize the problem. And an important thing that I think could help everyone is always keep in mind the difference between minimize and normalize. If we minimize a problem, we are not doing anything good for the patient because we are not validating his feeling and his pain. But we can normalize. So after the validation, I know you feel like that. I can see you feel like that. You have the right to feel like that. But, and then you try to normalize. It's just a finger. So you can try you can try to interact with their cognition, with their level of thoughts, only when they feel accepted in terms of emotion.
Thank you.
If you have any other question, you can still go ahead and ask. There's a comment from John. Everything is interesting so far. Thank you for the session. So yeah, I think
Thank you, John.
Neha, if you allow me, I would like to also add a couple of things that psychologists can really help in terms of medical conditions, you know. So Dr. Claudia was mainly focusing on emotions and diabetes. One of the most important thing for psychologists to help with in diabetic care is adherence therapy. So cognitive behavioral therapy can be used to improve compliance with the treatment, with taking medications, with blood tests, you know, with attending appointments. So we get referred a lot of patients from the DEC who have issues with this, especially young people who really need time to kind of adjust to the diagnosis and the treatment and change in lifestyle and so on and so forth. So adherence therapy is evidence-based in terms of using cognitive behavioral therapy. There is also sleep disorders. So there's lots of problems with insomnia that can be treated by using the CBTI model, cognitive behavioral therapy for insomnia. And of course, finally, the pain management. So CBT is also evidence-based as part of a comprehensive treatment for chronic pain, especially when there is no clear physical reasons for it. So these are things to keep in mind in terms of, you know, family doctors and other disciplines when they are seeing patients who are not improving or not adhering to treatments and so on.
Because I think every physician who works with any patient knows that adherence to therapy, whatever we may give them, if they don't adhere to it, if they don't follow it, it's all going to be, futile. So I think, yes, like you said, we can work as a team. We can decide their treatment, but then you can help us make them stick to it and, bring about the changes that are necessary. So excellent points there. Any other questions if anybody else wants to ask the team? Dr. Claudia is here. She's happy to answer any questions, any situations you may have faced where you think, there might be some involvement of their mental health, where counseling or psychotherapy might help them. We're also posting the links for the post-lecture assessment and the evaluation form in the chat box. Please ensure you fill them so that we can approve your certificates. Okay. Yes, there is no more questions in the chat box. If Claudia, if you want to add anything.
Any of you that needs some information, it's more than welcome to reach us over email or with the phone, because sometimes maybe you need just a few things, and we are absolutely available to clarify each point or give suggestion if we can help.
Just one question while we are here. Like sometimes when we break news to a patient, we give them a diagnosis, especially things like diabetes or even in our pregnancy cases, things that aren't going very well. There is a lot of denial that we see. Especially like for some patients who are like completely healthy, but then they're diagnosed with gestational diabetes in pregnancy. And they are shocked that how could they, get a condition like that. So any tips on how to help them get over the initial denial that they get?
First of all, the point is the way we deliver the information. So if the information is more medical, clinical orientated, it's different than if it's more psychological orientated. And again, we need to keep in mind the difference between minimize and normalize. We cannot minimize gestational diabetes, but we can normalize. So we can give them like the incidence in the population, how often it happens, to how many people it happens, which is the outcome. So if we normalize the problem, if we give them the feeling that we know as a doctor what exactly is the problem, and we know exactly which is the solution, and we are providing for the solution, it's easy for them to process this event like something negative that can be overcome. When they normally go in denial, it's because they get the information and their brain doesn't know how to process, how to overcome the problem. So we need to be solution-oriented more than problem-oriented. Even the epidemiology is something very, very helpful, especially for me. When we have someone with anxiety and they ask you, why me? I have anxiety, why me? Like, anxiety has an incidence of 23% in the mondial population. So it means that two people out of 10, they have your same problem. So you are not alone, and it's not that rare. And it's not that you are the unlucky one. It's just a condition. We identify the condition. We have the solution for this condition. Let's go through the solution and offer them an outcome that is reliable, realistic, and easy to be processed.
Wrap up here if nobody has any more questions. But if you do, we still have a few minutes. Please don't feel shy or don't feel, as it's a very small problem or a big problem. You can ask any question that you may have in your mind. The team is here. Dr. Claudia is happy to answer your questions. And that's the whole point of these interactive sessions, that you can ask your questions and, get some solutions, like Dr. Claudia said. So Okay, I think we've given everybody enough time. They've thought of it. They are absorbing what you've told them. And there's a question, should we mail anything? Well, if you want any further information or you have any questions that you think of, you can mail to Academic Affairs. We'll forward it to Dr. Claudia and get you some answers. Or if you need any further information, they'll be happy to guide you. So, okay, Dr. Claudia, thank you so much for this very interesting session and very informative. Thank you. Everybody have a great end of the year and season's greetings, and we will see you all in the next year.
You too. Bye.